This is our presentation on total hip arthroplasty and regional anesthesia in the elderly by me, Salik Rasul, and Tyler Mantle. Below are the objectives for this presentation. Total hip arthroplasty results in considerable nociceptive and inflammatory pain due to deep tissue trauma and manipulation of the joint capsule and surrounding structures. If pain is not effectively managed, it can lead to significant functional impairment, delayed mobilization, and increased risk of complications such as thromboembolism or pulmonary issues. Beyond the immediate discomfort, poorly controlled acute pain can induce central sensitization, a process where the central nervous system becomes hyperresponsive to stimuli. This increases the risk of persistent postoperative pain and significantly raises opioid requirements in the early recovery period. Regional anesthesia techniques act by blocking afferent nociceptive signals at the peripheral level before they reach the spinal cord and brain. This mechanism not only provides effective pain relief, but also prevents the initial triggering of central sensitization. When applied preemptively, regional anesthesia supports improved postoperative outcomes by reducing opioid consumption, limiting side effects, and promoting earlier mobilization. Overall, it plays a vital role in enhancing recovery while minimizing the burden of systemic analgesia. General anesthesia carries significant risks, especially in elderly and medically complex patients. It's associated with a higher incidence of postoperative delirium and cognitive dysfunction, both of which are particularly concerning in older adults. Hemodynamic instability, including hypotension and bradycardia, is also more common under general anesthesia and can complicate recovery. These effects are especially dangerous in patients with underlying cardiac disease, where even brief episodes of hypotension can lead to myocardial ischemia or worsening heart failure. Beyond neurologic and cardiovascular risks, general anesthesia increases the likelihood of pulmonary complications such as atelectasis and impaired gas exchange, particularly when mechanical ventilation is required. These risks are amplified in patients with pre-existing conditions like COPD, OSA, or bronchiectasis. Regional anesthesia offers a safer alternative when feasible, particularly in elderly or high-risk patients. By avoiding airway instrumentation and preserving spontaneous ventilation, regional techniques minimize pulmonary compromise. Crucially, they also reduce the likelihood of hemodynamic swings, which is especially important in patients with significant cardiac disease. Maintaining stable blood pressure and heart rate during surgery reduces the risk of cardiac events and supports smoother recovery. Additionally, regional anesthesia limits systemic drug exposure, lowering the risk of postoperative nausea, vomiting, and delirium. It provides excellent analgesia, which supports early mobilization and results in lower opioid requirements. This opioid-sparing effect further reduces the risk of sedation, ileus, urinary retention, and respiratory depression, factors that often delay recovery in adults. In short, when clinically appropriate, regional anesthesia provides a safer, more targeted approach that improves surgical outcomes and enhances recovery in elderly and high-risk patients, especially those with cardiovascular disease. In total hip arthroplasty, several regional anesthesia techniques are commonly employed to provide targeted opioid-sparing analgesia. The goal is to anesthetize the key nerve distributions responsible for innervating the hip joint, while minimizing motor blockade and systemic side effects. The fascia iliaca compartment block is a widely used anterior approach that can anesthetize a femoral nerve, the lateral femoral cutaneous nerve, and, through high volume spread, the obturator nerve. It is relatively easy to perform and has a favorable safety profile. The lumbar plexus block, also known as the psoas compartment block, offers a more consistent coverage of these same nerves, but carries a slightly higher risk due to its deeper location proximity to the epidural space. It is particularly useful for more extensive analgesia. The quadratus lumboris block, or QL block, especially the anterior and or transmuscular approach, has gained popularity due to its potential spread to the paravertebral space and lumbar plexus. This can result in both somatic and visceral analgesia, making it suitable for both anterior and lateral hip pain. The sciatic nerve block is often added to supplement posterior coverage of the hip, particularly important when posterior surgical approaches are used. Finally, the PENG block, or parascapular nerve group block, is a relatively newer technique designed specifically to target the articular branches of the femoral obturator and accessory obturator nerves. It provides focused anterior hip analgesia with minimal motor impairment. Choosing the appropriate block, or combination, depends on the surgical approach, patient anatomy, and comorbidities. These techniques provide a versatile, individualized way to optimize perioperative pain control and total hip arthroplasty.
On a case report, it was a 69-year-old male. He had a history of hypertension, diabetes, coronary artery disease. He had had a previous MI that left him with severe left ventricular dysfunction. So they were concerned about hemodynamics throughout the case. They decided to do a regional block, combined lumbar and sacral plexus block. They ended up doing the procedure without intubating the patient. He was managed just on a nasal cannula with a propofol infusion. They did not have to give any opioids throughout the entire case. And then post-op, they just gave him an infusion of ropivacaine through sacral and lumbar catheters that they had left in place when they did the initial block. This report we found, it was a 75-year-old female. She had bronchiectasis with a lot of secretions. She was having a productive cough. So she was high risk for general as well. They were concerned about whether they were going to be able to extubate her after the procedure. She also was having such severe pain that she was unable to reposition laterally to do the block. So in a supine position, they did an ultrasound-guided lumbosacral plexus block combined with an anterior quadratus lumborum block. So just like with the last case, this patient also did not have to be intubated. They were also managed just on a nasal cannula with a propofol infusion. She as well did not receive any opioids throughout the case, and then she had a post-op pain score of 0 in the PACU. Both of these cases that we just talked about, the patients were at an increased risk for peri-op complications from receiving general, being intubated, and just receiving the heavy opioids. Case 1, by doing the regional, they were able to avoid the hemodynamic complications. They didn't have to get the big doses of induction medications. They also did not have to get managed with inhaled agents. Both of those can cause hemodynamic issues, especially in a patient with cardiac issues. In case 2, they had concerns about whether they were going to be able to extubate the patient after surgery. By doing the regional block, they were able to just avoid intubation altogether. All she needed was a nasal cannula, and they didn't have to worry about extubating her afterwards. And then just in general, elderly patients that don't have any significant comorbidities, they're still at an increased risk for post-op complications, such as atelectasis, pneumonia, especially when they are intubated and then receiving post-op medications like opioids. They already have decreased lung function, so they're at risk for hypoventilation with the opioids, with the reduced ambulation. So just by doing the regional blocks, they can avoid that as well. Effectiveness of regional anesthesia in combating post-op pain and intraoperative pain, it's become a routine part of ERAS protocols. In a systematic review consisting of 87 randomized controlled trials, Lee et al. Found that opioid consumption and post-op pain levels were consistently reduced across all studies, utilizing numerous different types of blocks. They found that the most effective blocks were lumbar plexus, PANG, and quadratus lumborum blocks when combined with local infiltration by the surgeon. And then they recommend the quadratus lumborum, erector spinae blocks, lateral femoral cutaneous, and PANG blocks if you're looking to avoid motor blockade. That way the patients are able to participate in physical therapy in the early post-op period. The study that we found was a retrospective analysis. When they went back and reviewed, they did chart reviews on patients that had already undergone total hip arthroplasty. There was 59 patients that had received a PANG block, and then 57 patients that had received no block. They looked at the average fentanyl administration intraoperatively, and what they found was that the patients that had not received any blocks had received almost 300 micrograms of fentanyl on average, and that was compared to the patients that had received the PANG blocks, where they received only on average 50 micrograms. So basically the patients that had no blocks received almost 6 times as much fentanyl. Implications are just that in general, regional anesthesia reduces systemic drug exposure to elderly patients. As we said, even patients that don't have any significant comorbidities, they're still at risk. So we can reduce the amount of drugs we're giving them throughout the procedure, and post-operatively we can avoid those complications such as atelectasis, pneumonia, and then it also avoids hypotension and bradycardia, which you might see with like a spinal and a general anesthesia, as I just said. It's an excellent option for patients that have pulmonary and or cardiac comorbidities, just like we highlighted with the 2 case studies. And then combining blocks, you can improve coverage and outcomes and have better effects.
To conclude, elderly patients undergoing total hip arthroplasty benefit significantly from regional anesthesia, primarily due to reduced cardiopulmonary risk. When paired with monitored anesthesia care, well-planned blocks provide a safer and more targeted anesthetic approach. Current evidence strongly supports using regional techniques as the first-line strategy in high-risk populations. And finally, careful selection and precise placement of blocks can optimize both safety and recovery outcomes for this vulnerable group.